Thank you, Dr. Shakila Dil Afroz. I would like to thank our Honorable Principal Sir, respected Chairperson of today's seminar, and respected Chairman of the Scientific Committee, all my senior doctors and my fellow intern colleagues. Assalamu alaikum. Now I am going to present the literature review of today's topic, which is spondyloarthropathies. It is an umbrella term applied to a group of rheumatic diseases with features in common and distinct from other inflammatory arthritis, particularly rheumatoid arthritis. The common spondyloarthropathies are axial spondyloarthropathy, reactive arthritis, psoriatic arthritis, arthritis with inflammatory bowel disease. Here is a spectrum of axial spondyloarthritis to ankylosing spondylitis. Here in the diagram we see the axial spondyloarthritis is nothing but a pre-state of ankylosing spondylitis. So why should we diagnose axial spondyloarthritis earlier? It's just because we don't want the disease progress to turn into ankylosing spondylitis, so that we can offer our patient a better quality of life. Common clinical features of all spondyloarthropathies are asymmetrical inflammatory oligoarthritis, which is predominant in the lower limb, inflammatory back pain, sacroiliitis and spinal osteitis, enthesitis, which is the hallmark of all spondyloarthropathies, familial aggregation, HLA-B27 association, uveitis, which is the most common extraarticular feature. Ankylosing spondylitis. Ankylosing spondylitis is defined by the presence of sacroiliitis on X-ray and other structural changes on spine X-rays, which may eventually progress to bony fusion of the spine. Here we see the male predominance, which is 3:1 in male and female. In this diagram, we are also seeing some common clinical characteristics which we have already discussed. We do some investigations for the routine purpose, for diagnostic purpose, and for follow-up. The investigations are CBC, where we commonly find anemia, which is normocytic, normochromic. The ESR is often raised, CRP raised, autoantibodies, rheumatoid factor, ACPA and ANA are negative, HLA-B27 positive, liver function test, renal function test, tuberculin test, X-ray pelvis, X-ray thoracolumbar spine lateral view, X-ray chest peer view, MRI and DEXA scanning. X-ray pelvis, it is particularly very important, and there are two views, a simplified anterior-posterior view including the hip, and for more better visualization there is a modified Ferguson view, and there is a grading of sacroiliitis. We can see the picture. First of all, there will be fuzziness of the sacroiliac joint and irregularity and loss of cortical margins of the sacroiliac joint. Next, there will be marginal erosion of the cortical bone, then widening of the joint space, and eventually fusion of the joint space, which indicates the advanced disease. There are some bad prognostic marker of the disease, HLA-B27 positivity, then CRP high titer, and Rajshahi score more than 4, and poor functional capacity. Here's a picture of Rajshahi scoring. There are some there is a questionnaire we can see, and here's the link given we have discussed previously. Thank you everyone. I would like to invite Dr. Tahira for further discussion. Assalamu alaikum.